Thanks, Crystal, for the great introduction. Very happy to be here. We have a very interesting panel. So today we'll be talking about how AI can help in cardiovascular imaging. So let me start off with a question to Florian from Nurea. Florian, can you kind of tell us about areas where vascular imaging, where AI can help in vascular imaging?
Yeah, thank you. Thank you very much for the introduction. Well, I think that analyzing vessels is quite time-consuming for physicians. It usually requires CT scans with contrast product, which is not good for the patient. So it's hard to automatize, systematize the way you do these analysis and make sure you're providing a reliable diagnostic and decide a reliable strategy for the patient. So I think that's where AI can play a role in automatizing all these steps, providing much more data to allow the physicians, the radiologists, to take the right decision as fast as possible.
Thanks for those words. Moving on to Daniel. Daniel, can you kind of, you're from the cardiac MR domain, so we've had these problems where annotating cardiac MR is time consuming. There's a lot of intra and inter reader variability. So can you kind of give us an overview of how AI can help in cardiovascular MR?
Of course, Rail. Very happy to. And two questions in there, so address them in sequence. So number one, in terms of the time savings, you're absolutely right. I think there's something unique with the cardiac MR. For example, if I compare it with, I was discussing with Florian in the background before we started. So his solution is obviously for CT and in aorta. With cardiac MR specifically, not only you have the spatial aspect, so you have to cover a spatial aspect to it, but it also has a moving target, right? So you have to measure it and do the acquisition across the multiple phases. So that can quickly become quite a busy study. So for example, just to keep it simple, if I would do a function exam, I would need to do, let's say, 10 to 12 slices across the space, but then I will need to multiply that across the phases as well. So quickly, you can come up to 300 and something images that the physician needs to annotate, okay? And then on top of that, there's multiple annotations that needs to get done there. So if I multiply that by, measuring the endocardium, the epicardium, so I can get the mass as well and the RV as well. So you need to multiply that by 3. So suddenly you have 900 images that the physician needs to annotate. So with that being said, I think it's no surprise to anyone that a typical average cardiac MR exam can take 60 minutes in average. And with AI, at AI for CMR, we developed a solution that takes that to up to 14 times quicker, okay? And in average, we do 5 to 6 times quicker. So the largest gains are done on normal patients. So normal patients, I shouldn't be losing time with normal patients, right? I should be quickly in and out, looking at the AI measurements. Do I agree with them or not? And then quickly finalizing the report. And then obviously saving my precious time to tackle the more complex exams. So that's one way that AI can save time. In terms of the aspects around the variability, I think it goes without saying, and some of you will know, for cardiac MR, it is the gold standard for function analysis. Notwithstanding, the inter-rater agreement for the technique itself is about 85%. So it means that even though the exam is really precise, the users don't typically agree with each other, right? And AI, it's kind of an unspoken value of AI, where AI can come and help standardize things. So for instance, and one of my clients said this to me, so basically to their fellows, don't mess with the contours unless you have to, because that really helps standardize the technique, right? Imagine that patient comes later on and that you have to repeat the exam and you are actually looking at the contours that were done beforehand. You actually need to have a toe-for-toe comparison. Okay, so that's kind of an unspoken value of AI. It can really help standardize the measurements.
Thanks, Daniel. Moving on to Orat. Orit, your solution is on the cardiac CT domain. It deals with the population health. So can you give us some examples of what clinical results can healthcare organization expect to see? And also, could you include how this would help in return on investment?
Absolutely. Well, firstly, thank you very much for having me. At our company, in Nanox AI, we take a very different approach for cardiac evaluation. The majority of patients are getting CT scans right and left between the ages of 40 and 70 for many, many, many different reasons. But radiologists traditionally, I'm a radiologist, so I can speak about us, don't typically comment about the amount of coronary calcium with the non-contrast chest CTs. And many, many patients are going undiagnosed with cardiovascular disease, showing up in the ERs with their first heart attacks way later in the disease process. So we took a population healthcare approach for CT scans of the chest, and we analyzed all the CT scans that are non-contrast, performed for any reason at all, whether it's COVID or rib fracture or trauma or pneumonia, and we're always standardized. As my colleague said, there's an issue of standardization. One radiologist's mild is the next radiologist's moderate calcium, and most radiologists don't mention it at all. Standardizing, evaluating all CT scans with a coronary calcium score that's provided as a standard will increase the detection of the #1 risk factor for a future cardiovascular event, already known in all the cardiac literature. It's way more important to know your coronary calcium score than it is to know if you're a smoker or if you're a drinker or all the other risk factors that traditionally were used to evaluate for cardiovascular disease. All that rich data is available on CT scans that are performed in ERs and emergency rooms and hospitals and imaging centers all day, all the time, and that data is just not utilized. Our approach is to find patients, get them to appropriate treatment. In Corewell Health, where we're implemented, we published last year 1 year of data just at that one institution where our product was commercially deployed. In that one institution over a 1 year period, we found almost 4,000 new patients never previously diagnosed with cardiovascular disease that are now going on to get appropriate evaluation and treatment. That downstream evaluation and treatment brings in a significant ROI for the institution. These are patients that are now getting appropriate medical care, hopefully decreasing the number of cardiovascular events in their future. So downstream, long term, there's cost savings, but immediately there's workup and treatment for these patients that brings in millions of dollars to hospital systems across the board by applying appropriate preventative health care. So that's our approach to the world of AI and chest CTs for cardiovascular detection.
Thanks, Orit, for the answer. Switching to, so we've heard about how AI can help in the cardiovascular domain. So what I would like to hear next is some use case stories on how it was deployed and how people are using it currently. So probably let's start with Florian again. Florian, do you have any insights that you would like to share with us?
Yeah, with our current solutions, we have 3 different use cases. As everything's fully automatized, you can use that solution in different step in the healthcare pathway. So our first application is to help radiologists identify aneurysm stenosis on exams that are not targeting this kind of diseases. So that's one of the first use cases we've tried. So it's really adapted to deployment, like with Blackford, where you can analyze a huge amount of data, the whole floor of CT. And we have demonstrated in some hospitals that we've increased by 10 to 15% the number of cases they've been able to diagnose, and that was necessitating an intervention. So then we go to the second use case, intervention, because we are not just providing information on whether or not there's an aneurysm, for example, but we also provide all the data to plan the intervention, select the device they're going to need. So of course, if you have a center and you're able to detect more disease that needs intervention, well, you save patients, very likely. And you also, from a more financial side, you generate more intervention and more money for the hospital. And this step of surgery planning is really key in the decision of selecting the device and the procedure. it suffers of all the issues that have been mentioned previously about reproducibility, interoperator variability, time, because you need to extract dozens of measurements, and we do that automatically in a few minutes. And we standardize the way it's done, and it helps selecting the correct device. And then the third use case is when the patient already had the intervention and is followed regularly with a CT, then you need to know how the disease is evolving. The particularity of the kind of disease we address is that they're treated most of the time endovascularly, so you kind of isolate the disease, but it's still there. So you need to follow it carefully. And that's where you need something that is reproducible, because if you need to compare data, you need to make sure that they are comparable. And that's a third use case. And on that, we had very significant cases where people were not sure, physicians were not sure how this was evolving, but the patient was suffering from back pain, abdominal pain, and they didn't know if it was really coming from the aneurysm, because he already had a quite heavy surgery. So they used our solution to really monitor how the aorta was evolving and where it was evolving the fastest. And they decided to go to surgery. Probably a patient that would have waited additional days or weeks to get another exam and hopefully get an intervention.
Yeah, thanks for that. That was quite insightful. Daniel, how about you? How is your solution being used, and what can you tell us about it?
Yeah, so same question. I could give you numerous kind of use cases for Valley, but I'll actually use one because it's fresh on my mind, because it just happened yesterday here at our SNA, and I found it curious because a client highlighted it to us, and we haven't thought using it like that, so I find it curious. But in any case, just for context, so our solution works in a way where it's zero-click, it's no interaction from the scanner. So once you're actually acquiring the exams, you send that through our gateway, through the cloud. The exam is automatically analyzed via computer vision. We identify the specific sequences that require the specific annotations and analytics, and then we do the proper analytics to each one of the sequences. And again, this is completely without any human interaction. And because we do that without any human interaction, we can also detect specific disease, for instance, instances where wall motion is affected in the patient. And that allows us to basically return not only the annotations and the DICOM images, but as well enrich the work list for the physician with that information. So I will actually know if a patient has a higher probability of being normal or not, and I can actually prioritize my work list in risks or impacts wherever the physician does the reporting. And what a customer of ours said to us yesterday here at RSNA is a customer in an hospital in Lisbon. He mentioned that not only does it actually uses that information to prioritize the exam, but he actually, to be more efficient, he allocates exams that are potentially normal to fellows in training, and then he actually takes on the more complex cases to the more expert physicians. So that obviously has immense savings and obviously productivity gains. So that was fresh on my mind. I thought a unique case that we haven't thought about, but it just showcases the value of AI. I think we're just at the cusp of what AI can do. So the future is very bright.
Thanks, Daniel. That was really interesting how people can use AI to make them more efficient. Orit, are there any use cases that you would like to share with the audience, like how your solution is helping the population, health, etc.?
Absolutely. So in particular for lung cancer screening, where all the chest CTs are done without contrast, it turns out that while it's a federally mandated program to find patients for lung cancer, more people in that category actually die from cardiovascular disease than they ever died from lung cancer. And so there's a lot of information on those CT scans. Radiologists are supposed to comment on the cardiac calcium within the heart to maximize the study. Some do, some don't, and there's no standardization across the industry. Again, one person's mild is the next person's moderate. And cardiologists have a hard time knowing how to treat the patients with such vague terminology. When you translate that to a cardiac calcium category and a cardiac calcium score, the primary care physicians and the cardiologists know exactly, based on clinical guidelines that have been published for years, what to do with a patient, how to funnel them to appropriate medical care. So standardizing it across the lung cancer screening industry is really to get patients to the appropriate care that they need in a timely manner. So that's just one use case. But as I said, at Corwell Health and our other locations that we have, increasing, social equity of medicine is another direction with our product, because at the end of the day, we're screening all the CT scans that are coming through the ER and to the hospitals, some patients with insurance, others with not, patients who are not necessarily getting appropriate preventative health care, which turns out to be, unfortunately, the majority of the U.S. population. Having standardized clinics, being able to find patients, not lose them in the ER, but direct them to appropriate medical care, will ultimately improve the equity of medicine in the U.S. today. And so we have a powerful motive behind what we're trying to do, improving population health in cardiovascular disease. And we have other products in population health for also osteoporosis and fatty liver disease along the same lines.
Thanks, Orit. I just saw Dr. Murtaza walk in. Thank you for taking some time to join us in this panel discussion. So we've been discussing about how AI helps in the cardiovascular domain. So maybe a quick question to you. Can you kind of give the audience a brief insights on your solution and how it's helping the population health?
Sure. Sorry, I'm running late, Adrian. I have to tell you that we are pursuing a very ambitious goal to bring AI to the forefront of early detection of cardiovascular disease, both in the asymptomatic arena, which is like 80% of our population, and the symptomatic. So let's start with symptomatic, the easy one. So patients come to emergency room in the US, about 12 million with chest pain. About 1.5 to 2 million actually are coronary disease cardiac patients. Without AI, we're doing what we're doing today, which is keeping the rest of them all in the ER for 12 hours, 10 hours, do all kind of testing. So we hope that AI will cut down that to less than 3 hours and let everybody else who is not high risk go home, less than 3 hours. That would be a major success and reduce a lot of costs, unnecessary costs. So that's symptomatic. And that would be applying AI to coronary artery calcium scan, a regular non-contrast. If your CAC 0 and your heart score is below 7, you should not be staying in the ER. That's basically our AI algorithm. And we have data to support that. And we're going to CMS December 11th next week to talk to them about this. The asymptomatic is the biggest pie, as you know. So we have about 50 to 65 million people fall in the intermediate risk category, according to AHA-ACC guidelines, meaning we don't know exactly what to do with them. The ones that are low risk, they don't need any treatment. The ones that are high risk need treatment. But the low risk and high risk are less than 30%. The rest of them are intermediate. So applying AI-enabled coronary artery calcium scan, not a score, a scan, allows you to take these bulk of intermediate and properly categorize them to low risk and high risk. So the low risk is about half of them, they don't need treatment. The high risk is about half of them that need intensive treatment. So our first step is coronary calcium scoring. We have shown that AI can improve the power of 0. Everybody who knows calcium score knows that a big value of calcium score is power of 0. We have shown our AI can improve that, and it's a study is sponsored by MESA. We also are able to see things that a physician cannot see, and that's cardiac chambers volume. So we just got FDA breakthrough designation and marketing authorization for what we call auto chamber. So a non-contrast chest CT scan, you can report cardiac chambers volume, and Adrian and the team at Blackford are preparing to introduce it to patient care. Then you don't stop there. Around the heart, there is bone density right behind the heart. Our AI is also FDA approved. We have just finished the same way Nanox team did. Our liver, we have a slightly different approach for osteotosis. We also found myosteotosis, meaning fat droplet in the muscle, is a highly predictive of future cardiovascular disease. So in summary, there's an ocean of information hidden in a regular non-contrast, low ball chest CT scan that we can use with AI to advance healthcare.
That's really interesting. Thank you for the answer and explaining to the audience how AI can help. So we have like 2 more minutes remaining. So I would like to ask the audience if there are any questions you would like to ask the panelists. Okay, if that's not the case, then we'd like to thank all the panelists for taking their time off and coming and talking to us and educating us on the role of AI in cardiovascular. Thank you very much.
Thank you.